has agreed happily to present for us this morning, or afternoon for those of you in East Africa. Happiness, as most of you know, is one of the master students in the TREC training program, which is an NIH funded D43 program, supporting several of our team members in studying epidemiology and biostatistics. But she also has been working with Emily Smith and a great team on some pediatric cancer work and some other registry work in the past. So they have a great, this is a published paper, right? To present, which you guys can look more in detail, but Happiness is gonna introduce that to us. And without any further ado, I think I will let you take it away, Happiness. You should be able to share now.
Okay, can you all hear me?
Yep.
Okay, so I'll show my screen. Please let me know if you can see my screen.
Yep. Looks perfect.
Okay, so can I start?
You may, please.
Okay, so thank you so much, Ashley, for the introductions. As she said, I'm Happiness. I'm a master's student in epidemiology and applied biostatistics. And today, on behalf of my team members, I'll be presenting a paper that we published in BMC Cancer on the impact of COVID-19 pandemic in childhood and adolescent cancer care in northern Tanzania. And this was a cross-sectional study. So this will be the outline of my today's presentation. And to start with a bit of introduction, so we know that globally, about 400,000 children are diagnosed with cancer annually, and this burden is situated mostly in the low-middle-income countries where 85% of childhood cancer deaths are said to occur. And despite the oncology burden for children, we see that most oncology services in low-middle-income countries are very low in terms of priorities for funding, as well as the global health agenda. And we only saw that like 5% of the global cancer funding does go to the low-middle-income countries. So in 2018, the WHO Global Initiative for Childhood Cancer was launched with the aim of increasing survival for children with cancer globally to about 60% by 2030. So in the context of Tanzania, about 3,000 children are diagnosed with cancer annually, and the survival rate is reported to be about 5 to 10%, which is very low compared to other high-income countries where survival is reported to be over 80%. And this burden is more pressed by limited resources, where we only have like one pediatric oncologist in the northern Tanzania out of 6 that are available within the nation. So looking at the COVID-19 impact, in different areas, we know that COVID-19 did highlight systemic health inequalities as well as disparities in care, but also in terms of oncology, it did disrupt a lot of oncology treatment, including chemotherapy, radio, as well as availability for surgery. But also a study that was conducted in Tanzania did report there were disruptions in adult cancer care, and there was increased reliance on traditional healers, which led to late presentation. So in the context of pediatric cancer, this led to the aim of our study, where we wanted to assess the impact of COVID-19 pandemic on access to cancer care for children and adolescents in northern Tanzania. And mainly we wanted to compare their diagnosis, treatment, and outcomes during the, pre-COVID era and during the COVID-19 pandemic. So looking at the methodology, I'll start with a brief introduction on study setting. So we did this at KCMC, which is one of the 4 referral hospitals within the country, and it serves nearly like 11 million patients annually. And it is one of the hospitals with only 1 out of the 6 pediatric oncologists nationwide, as I said. And most services that are provided for children with cancer include diagnosis, treatment, but also research activities and community outreach that is being done. So KCMC has been graced with a lot of collaborations. Thus, medical costs for children with cancer are usually catered for, so children don't have to pay any direct medical costs to be able to receive care at KCMC, which is good news, at least from our side. So the data sources, we used the Kilimanjaro Cancer Registry, which is a member of the African Cancer Registry Network, and it was established in 1998, and it does include pediatric data since 2016. So we narrowed our study period from January 2016 to December 2022, and our population was all children and adolescents aged 0 to 19 years who were newly diagnosed with cancer. So the variables we collected the demographic variables, including age, sex, travel time was estimated using Google Maps and regions which these children were referred from, but also clinical variables included like the diagnosis, the treatment type, and the cancer stage at the time of diagnosis, and vital status at the end, whether the child was alive, dead, or unknown. And cancer classification, we classified it according to the International Childhood Cancer Classification, the 3rd edition, with 12 cancer site groups, where like we have group 1, including leukemias, group 2, lymphomas, etc. And we did want to compare, like before COVID-19 and during COVID-19, we wanted to compare the staging and diagnosis for these children. Now, we know one of the limitation for us would have been that we know that different cancers for children are grouped, the staging is different. For instance, for solid tumors, we use the TNM staging. For Wilms tumor, we do use like the SIOP. So we did have to use the adapted ACRN guidelines for the LMICs for staging of cancer registries to be able to stage the cancer at diagnosis for these children. So the study periods, we did specify the pre-COVID era as from 2016 to 2019, and the COVID era from 2020 to 2022. And in terms of analysis, descriptive statistics, we compared like the demographic and clinical characteristics of these children by era, that means by pre-COVID and COVID, and by age group. But also we did inferential statistics where we compared diagnosis by year and by disease stage between eras. And also we assessed like the surgery rates before and during the COVID-19. And we excluded the hematological malignancies because we know that like the primary treatment for hematologic malignancies is not surgery. So we only included solid tumors to assess surgery rates. And we analyzed disease stage at diagnosis that was only available for 167 patients out of 547 children. And we used starter version 15 to do the analysis. So to dive into the results, I'm not so sure if it is very visible, but for the table 1, we really liked to look at the demographic and clinical characteristics before and during the COVID-19 pandemic. And as you can see, as I'm sending in like the cursor, So we see like in the pre-COVID era, we had like 190 admissions compared to the COVID era where admissions nearly doubled to like 357, which is 65.2%. Looking at the age groups, we see that those children that were aged 5 to 9, the admissions increased compared to children which were in other age groups. But also looking at the treatment, we see that children who received surgery pre-COVID, they're about 15.8%. And this also nearly doubled to like 30.8% during the COVID-19 era. But also in terms of death, we only see like a 1% increase in mortality during the COVID era compared to the pre-COVID era. Looking at this figure, the different colors represent the different groups. Like group 1, if you look at the figure below, it shows like the leukemias, group 2 lymphomas, etc. And we can see that the distribution of diagnosis by site group across all years. In 2016, you would notice like there were like a minimum of like 5 groups that were diagnosis of cancer for children. But this rose to like in 2021, where we see like 12 groups of cancer were being able to diagnose during this period. And when you look at my right, you see that even in 2021 was the peak year where we saw a lot of admissions for pediatric cancer with 31.8%. When we go to the second table where we tried to look at the stage of diagnosis before and during the COVID-19 pandemic for only 167 patients whose information was available, we can see that across both eras during the pre-COVID and the COVID-19, late stage presentation was predominant, but it did slightly increase during the COVID era from 77.3% in the pre-COVID to 84.8% during the COVID era. And we see that only the children that were under 5 were mostly affected, where the late stage presentation increased from 29.4% to about 58.2%. Looking at the distribution of surgery that was stratified by cancer site group, so you'll notice like the first row is the pre-COVID, the second row is the COVID, and the colors show like surgery in my left, and those that like are dark brown are no surgery. So we see across all age groups, and remember for here, we only included the solid tumors. We excluded hematological malignancies because surgery is not like the primary modality of treatment. So you can see across all groups, like the need for surgery did increase. For instance, like in group 3, you see it went from 8.3% on my left to 67.9%. In group 10, we see like it went from 50 to nearly 100%, like all children did have to get surgery, with exclusions to group 12, where we see there's no differences in surgery rates pre or during the COVID-19 pandemic. And this, for the last figure, we see that our distribution of cancer cases by stage and age group. So you can see like late stage presentation did increase overall during the years. Compared to like in age, we see that mostly it's the younger children who are mostly affected. And we can see that even the admission rates in percent were increasing over the years compared in the pre-COVID as well as the COVID era. So key findings from this paper, we did see that there was an increased admissions. Despite the disruption that COVID-19 did bring, we see that childhood cancer admissions nearly doubled from 190 to 357. And we see that late stage diagnosis was on significant rise, of course, across both eras, but it did significantly rise from pre-COVID era to about 77.3% to about 84.8%. And we see that those children that were under 5, they were most commonly like affected because it increased from 29.4% to 52.8%. And some of the factors that we did see that could have contributed to this include, first, the healthcare system resilience. We know that the burn for COVID in Tanzania was different from other countries. So KCMC still maintained cancer services despite the pandemic, but also support for like free care, transportation, and free treatment did increase referrals, and that boosted admissions. But also for while late presentation, we do know that there were a lot of fears around COVID-19. So probably parents would have delayed bringing their children to the hospital. So that could have explained why we see a lot of late stage diagnosis during the pandemic. When we look at similar trends in low middle income countries, they did also report that there was reduced pediatric cancer services, but also they did report there was worsening outcomes. The increase in surgical rates, however, we only saw it at KCMC in comparison to other LMIC studies, which reported decrease in surgery rates. And an implication for this is more of like, there's a need for strengthening referral systems and community outreach, especially during health crisis. And it's important to like ensure resilient healthcare services during future health crises, if at all it happens again, so that we are prepared. And some of the limitations that we did find was first in data availability, where we saw like there is incomplete staging data, especially for a significant proportion of children didn't have staging at diagnosis. That's why we had only included 167 patients out of 547, and registry challenge because it couldn't capture information like absconding rates, loss to follow-up, and treatment discontinuity. So there are still data gaps in that area. So in conclusion, our study did find there is a significant rise in late-stage cancer diagnosis among children with cancer during the pandemic. And we see that surgical rates were on the rise, while other treatment approaches did remain stable. So an understanding of this is helpful in future adaptations for healthcare systems and interventions, so as to help the emerging needs for children and adolescents with cancer in the midst of any future health crisis. So these are references, and thank you so much for listening.
Wonderful. Thank you so much, Happiness. Questions or comments, please go ahead. I see there was a couple of things left in the chat. William was pointing out the 4-year versus 2-year study periods, and yet more cases in the 2 years compared to the 4 years. Really interesting catch, he says. Natalie added great graphics on your data visualization. Really cool. Comments or questions?
I have a million, but I want someone
Of
else to go
course,
first,
of course.
because I always have some.
Very mindful presentation, so Virginia.
I always have some.
It's not a question, but it's just a comment. I just want to say congratulations to Happiness because it's a very beautiful presentation. And I identified myself with this study because for example, in the pandemic period, for example, I was working at a hospital in a surgery center, and we could see how important and dangerous was the pandemic period, for example, to the healthcare system, because in that period, we have an order to stop, for example, elective surgeries, and we just attend emergency ones. So this results in overcharging to the health system. And after the pandemic period, for example, we have a lot of surgeries to do, and we don't have professionals as much to attend the demand. So have some studies comparing the pandemic period and after, and before and after pandemic period is very interesting. So I am doing this in my PhD project as well. So that's it. Congrats, Happiness, to the results. It's a very interesting study.
Well, first, also congrats. It was really well done, really a lot of data and very interesting. I think, we've talked in this group in the past about the perceptions of COVID in Tanzania and sort of like a lack of recognition of its severity and stuff at the time. Has looking at this data and knowing what the cultural attitude was during the pandemic, I guess, how do you overlap the two, or what has been kind of the discussion in Tanzania around, I guess, kind of results like yours, because there's been, kind of other work kind of showing really the impact of COVID. But has there been some reflection? I know that's not exactly data driven, like in your paper is very data driven, which is great. But what's just kind of your gestalt of how the cultural influence of the perceptions of COVID on findings?
I'm not so sure if I got it right, Charlotte.
I think I'm asking so the government in Tanzania was kind of saying COVID's not real, right? But then there's lots of papers like yours that show a broader health impact from the time. And so what amongst healthcare workers and data people like yourself, what has been the discussion now that we're out of COVID, looking at this type of work about what that means about healthcare? Broad question, so answer however you like. I'm curious, kind of the human element behind it.
Okay, that's a very interesting question, Charla. So I think it's very conflicting, especially in our context, because in the terms of healthcare, a lot of things the government has a say. So it's really like we know it just by speaking. We really don't have the data to support what our insights are on, like a reflection of after COVID. But I think a lot of clinicians can testify with me that despite the government keeping the barn, like maybe there is no COVID, or trying to put it in a way that maybe it shouldn't fear people, like the disease isn't there. But we can all agree as clinicians that we did see an increase in, let's say, not only in pediatric cancer patients, but also in different diseases, like an increase in admissions of patients who's attending patients. So I really can't say exactly, because we don't have enough data to support that, what are ongoing communications regarding COVID after mass. But I do agree with what you're saying. So yeah, maybe I'm not so sure if I've answered your question, but yeah.
It's good, thank you. I'll let the last question.
So I'm gonna play devil's advocate. I'm obviously an author on the paper, but I'm gonna try to rip apart my own paper just because that's fun sometimes. Happiness, I know you're gonna be able to answer this very easily, which is why I asked. There's a difference between causative and associative, right? We know that COVID doesn't cause you to get more surgeries. And yet we see that a lot more surgeries are done during COVID than not.
Mhm.
I don't think that's from COVID. I don't think that's from the COVID pandemic.
Mhm.
What do you think is happening?
So as you said, association is not merely causation. So maybe what I can say is that for KCMC, I think the fact that it opened doors to like free treatment and care for oncology services, not only like made people show up a lot when it comes to presentation for cancer cases. So the increase in like surgery could be also like increase in diagnosis of these conditions, and not just merely like the COVID-19 itself revealing, but rather like people noticing that there is a need to go to the hospital to get the child checked, and the fact that if it's a cancer, now it can be treated freely at KCMC. So I think it's not just the COVID-19, but also like in terms of parents and caregivers being able to like send these children to the hospital, knowing that maybe if it's surgery, it's going to be covered for. Like, yeah, that is what I think. But it's not, yes, as you said, merely related to just COVID-19.
Yeah, or the pandemic. Beautiful, beautiful responses I knew you would have. I do want to add that I think that when we start to look at data this way, we also have to be very mindful of what's happening at the health system. And our Tanzanians can correct me if I'm wrong, but there's been in 2020, strange timing, but in 2020, there was a very significant push for pediatric oncology and surgery. And so there's been a huge difference and a huge referral system set up and more cancer with the opening of the cancer center and the pediatric focus, pulling a little bit of patients away from Uganda. So I do think that some of this is that push, that health system development. But I would agree with you 1,000,000% that the delay in diagnosis, that's COVID. And so the way that you presented the data is perfect because you're really focusing on that delayed diagnosis or late stage presentation of the patients, because that we do think is the pandemic. But this diverse number of cancers that are there being represented, the more patients that are getting surgery, those components, I think that's health system strengthening happening as we speak, hidden in the data. And the different pieces of it, the fact that you were able to pull those apart and show what could be from what, I think was really nicely done.
Changes in documentation too, of course, are one of those changes of the health system.
Exactly.
We know that electronic health records have improved greatly at KCMC since the onset of the pandemic, I think it's fair to say. I'm wondering about that. Using secondary data, registry data always has challenges. Although it may seem simpler than designing your own data collection tool. It's generally more complicated. Well, I don't know. It's up for debate. It has its own complications as does primary data collection. However, to my point, you mentioned some of the data gaps, missing this or some incomplete cases. What I wonder, in your opinion, or any of the authors could add, what is, if you could have like identify one principal gap that if you had more, this particular variable or if this data were more complete, we could have said a lot more here. What were you really longing for when you were looking at the data available?
Good question. Good question, which I'm not so sure if I have a direct answer for that one, Ashley.
It's subjective, so choose whatever you like.
Yeah. Oh, sorry. Wait. Ashley, if I got you correctly, like in the data gaps that I did mention, you'd like to know if what specifically we would want to like improve for it not to be a gap or like a challenge in the registry?
Yeah, and what would be like, if you could name just one thing, what was missing in your data sets that would have, you were really hoping you had or wishing that you had?
Oh, I'm not so sure if I have an answer for that.
That's okay. It's kind of a
Mhm.
thought exercise more than a practical question, but it's sort of practical at the same time. Like, what would you advise the folks managing the cancer registry to do to improve the quality of the data?
Because I think part of our objective was to like really assess the impact, and we were comparing like the diagnosis, the treatment, and like the outcome. And I think if there was only like the pressing part of which maybe we couldn't get enough data was the part where we had to like look at the stage of disease at diagnosis, which was missing for most of the patients. Yeah, and is it because for the disruptions, like in terms of collection during the COVID-19 or the persistency? Because I think I can attest, compared to the COVID-19 currently, there's like an increase in RAs who are working on the KCR registry to like follow up the data and ensure its completeness, compared to like the COVID-19 pandemic era. So maybe that I could say like the stage of disease at diagnosis was really missing. Yeah. And we had to do like a sub-analysis for very few patients.
Like to add or any other questions, observations? Comments?
Happiness, I'll just jump in. I said in the chat that you're speaking like a true epidemiologist. We're all applauding you for that. Make sure you put
Thank
this on
you.
your CV too as a presentation.
Right.
I want, this paper was interesting to me because it's classic, like multiple things can be true at the same time. Of the resiliency, because I had worked with other countries and looked at the health system stuff during COVID-19, and all of them had underperformed for health personnel issues and stockouts or whatever. And then we get to the Tanzania, and it's the opposite for reasons that people have already talked about. And I think more of those stories of resiliency needs to be published, of how some LMICs actually performed better for lots of reasons, but despite the pandemic. Also, Tanzania is interesting. Charlotte, to go back to what you said about the COVID, perhaps hesitancy or something in the country. Tanzania was actually one of the first countries to reach a 75% vaccination rate early on because of USAID endeavors. And so I think there's an interesting on the ground versus maybe government. I don't know. I mean, I certainly don't know the government part, but I know the vaccination part in the country was interesting. And then let me go to the flip side, like two things can be true at the same time. It was awesome from a health system standpoint. There's still kiddos who are slipping through the gap, which were the little bitty ones that actually higher stage increased for those kids. So I think distilling that in a paper, at least for the reviewers that read this paper, it was kind of hard. There were times where I felt like you either needed to be all the way happy or all the way detrimental. And this is a classic example of both in the discussion. But happiness, well done on telling the story.
Thank you.
Final thoughts or questions? All right, well, let's thank Happiness once again. Great job. Epidemiologist in training, wonderful. Very good.